Good morning, all of you. Today, our guest speaker for the day is Dr. Aisha Soonawala from Mumbai. She is going to lecture us on optimal vaccination for hematological patients. This webinar is brought to you by Mumbai Hematology Group, supported by Pfizer and managed by Perfect Square. I thank Dr. Ankita Jain, Dr. Namrata Kulkarni and the team Pfizer, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Ratna Sharma from Mumbai, our guest speaker for the day, Dr. Aisha Soonawala from Mumbai, and all our discussants who are themselves eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday morning, afternoon, and evening. Now it's a time to introduce all our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Ankit Rayani from Pure Hematology Oncology Clinic from Ahmedabad, Dr. Ankur Ahuja, Assistant Professor, Department of Lab and Molecular Medicine, RNR Army Hospital, New Delhi, Dr. Asif Iqbal from Dr. Bhuvneshwar Baruha Cancer Institute, Guwahati, Assam, Dr. Dheeraj Bhattad from Sir H.N. Reliance Foundation Hospital Research Center, Girgaon, Mumbai, Dr. Dipanjan Haldar from Jupiter Hospital, Mumbai, Dr. Farah Jijina, Consultant Hematologist from KEM Hospital, Parel, Mumbai, Dr. J.M. Khungar from Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, Dr. Mahadev Swami from Manipal Hospital, Goa, Dr. Nishad Dakate from HCG NCHRI Cancer Center, Nagpur, Dr. Pranta Chakrabarti from Kolkata, Vivekananda Institute of Medical Sciences, Kolkata Fortis Hospital, Dr. Rajkumar Ramaswamy from Vellamal Specialty Hospital, Madurai, Dr. Riya Balikar from Wockhardt Hospitals, Nagpur, Brigadier Dr. Sanjeevan Sharma from Command Hospital, Lucknow, Dr. Satish Kumar A from Yashwantpur Manipal Hospital, Bengaluru, Dr. Soumya Bhattacharya from Apollo Clinicals Hospital, Kolkata, Dr. Suma T.L. she's a consultant pediatric oncologist from HCG Hospital, Bengaluru, Dr. Tejaswini Gudibande from Narayan Health Mazumdar Show Medical Center, Bengaluru. Now it's a time to introduce a special guest for the day. We have Dr. Ratna Sharma. Dr. Ratna Sharma is Senior Consultant and Clinical Lead, MCGM Comprehensive Thalassemia Care, Pediatric Hematology, Oncology and BMT Center, Borivali, Mumbai. Dr. Ratna Sharma is MD Pediatrics from St. G.S. Medical College and KM Hospital, Mumbai. Subsequently, she did her fellowship in Pediatric Hematology and Oncology from LTM Medical College and General Hospital, Mumbai. This was then followed by training in Pediatric Hematology, Oncology and BMT from Medical College of Wisconsin, USA. JESCAP Fellowship. She is also a consultant pediatric hematologist and oncologist at Jupiter Hospital, Thane. It's my privilege to introduce her and invite her to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Ratna Sharma. Thank you so much.
Good morning, everyone. Greetings on behalf of my team at CTC PHO BMT Center, Borivali, and the team at Jupiter Hospital, Thane. It's an honor to be here on this live webinar organized by Mumbai Hematology Group, connecting me with all of you. I would like to thank Dr. M.V. Agarwal for giving this opportunity to express my thoughts on how exciting this field has been, the field of hematology and oncology, and what the youngsters can look forward to in this field. So hematology, oncology, and BMT, which is now, the things that youngsters are looking forward to, are branches for those with very curious mind, I would say. The field has certainly evolved tremendously all over the world. And in India, too, we have witnessed a rapid pace in the last 2 to 3 decades, and we have been able to catch up with the rest of the world. So to talk specifically of pediatric hematology oncology, I don't know how many of you all are into only pediatric hem-onc over here. Yeah, but then because I work in the field of exclusively pediatric hematology oncology, I would say that because of the efforts made by the seniors in this field and the experts who started this branch in India, the curriculum of this field is very well defined now. The guidelines have been laid down for a lot of conditions, so there is a structured approach. There is a multi-centric research happening in this field, so I'm sure in future we'll have improvised treatment protocols that we all will witness. And with various specialty programs that are now going on in HEMONC, after post-graduation, and the BMT fellowships that are happening after this training program in HEMONC, the workforce has increased and the country is witnessing progress in the care of patients in this field. Last 10 years, I have seen that there's been a lot of, exciting work happening in this field, especially in the field of bone marrow transplant in our country, especially pediatric bone marrow transplant, because that was at the back seat basically. And with opening of new BMT centers across the country, both in private and public sector now, this has improved disease-free and overall survival in our patients, and especially the patients with specific cohorts of HEMONC patients and patients with inborn errors of immunity. The proportion of still the pediatric transplant to total transplant, is less obviously with the considering the population, but it is gradually increasing, and we have a long way to go. The population of considering the population of our country and the number of transplants that we manage to do, we have a long way to go because still we have patients, who are not able to reach transplant centers and undergo the treatment. The PHO community has, witnessed members of their own community who trained abroad and came back to India, and with their, enriched mind and enthusiastic personalities, they have set up pediatric or even adult HEMONC centers, including some of them have set up bone marrow transplant centers in the country. So this has led to a chain of, training programs by them to the next consecutive, generation. And therefore, we have enough workforce in our country now to take this program ahead. And the program has really become strong. Like till the end of the last century, the non-affording would be dying a premature death because they, couldn't get the treatment that was required. The very affording would be in the wait list of few centers who would be doing BMT. And the more affluent one would probably fly abroad and get a transplant done. But things have changed now, and the scenario is totally different. The waiting period is shorter. The non-affording also end up going to public sector hospitals where, funds are being raised with the help of government agencies and NGO schemes, and they do get the treatment which is required to, make them free of their diseases. So this is especially true for children. Like for our center, we have been doing transplants in 2017, and we started in Sion Hospital in 2015. So we have been able to give transplant as an option of treatment for patients, even if the family cannot afford, and by raising funds through NGOs and government schemes. So this is doable now. So, but yet there is a huge unmet need in the country, considering our huge population. So the youngsters definitely have an important role to play. The future seems bright, exciting, with increasing demand and availability of expertise, including more HEMONC units being set up. And a lot of hospitals, the corporate hospitals and the public sector hospitals are now including this as one of the important patient services that they're offering, in their own setup. So most of the fresh pass outs are being absorbed in our country, and some are going abroad to gain more experience, more advanced expertise. Quite a few of them are coming back to the country to offer services, or they are jointly working with programs, by being stationed abroad, but spending some time or liaising with the centers in our country, trying to improvise the health structure over here, the infrastructure of healthcare services over here. So it is working as a joint program in a lot of centers where we have our own colleagues who are settled abroad and guiding the team over here. And it would be interesting to know that some of the fellows trained with us have even gone back to their own hometowns and to the interiors of the country and set up HEMONC centers and transplant centers over there. So it is very satisfying and fulfilling. And some of those juniors have even been absorbed immediately because Indian students are more sought after. So some of them were immediately absorbed in research programs abroad. So that speaks volumes of our own training program over here, and it has been immensely satisfying. So what should be the goal now? The goal should be to ensure that no matter in which part of the country they are, as close to their homes as possible, no matter what is their affording ability, whether they approach the public sector or the private sector for treatment. With every case being unique, one is constantly reading and learning. So those who are interested should be prepared to be a student all their life. And we also need to know that it is not one consultant's role which is going to decide, the knowledge or the skill of a single consultant which will decide the outcome in your patients, because ultimately it's a teamwork. So it's not that, if you are very good, your patient is going to do well. It's not that way. So the team is important. Building a team is important. Ensuring the sustainability of the team is equally important, because you need to stay, you need to share your stresses, you need to share your credits. So if you are willing to do that, that you're going to be a part of the team, then you can go ahead. Because if you, the HEMONC and BMT is best learned as a team, it is best practiced also as a team. And if you cannot be a team player, this is not the right place for you, because it's difficult to work single-handedly in this field. And you can do good patient care if you work as a team. You can do significant amount of good research. You can have a steady growth, in your own professional life with the presence of a team around you. So work as a team, grow with your team, and I think that helps you to grow in your personal life also, because you learn a lot when you're working as a team to adjust and grow together. And in a team, you continue to learn from your seniors. Obviously, they have more experience, and you learn from your juniors, because they are those, quick, sharp learners, and they help you to catch up with all that you didn't have in your curriculum in the past. So that definitely helps. And you always, I think you learn from your colleagues who have different strengths. So that really helps, because everyone has their own strength. So if when you're working in a team, you learn how to get the most out of people and work as a team together. So you in HEMONC and BMT, you need people from all specialities, because every patient, it cannot be managed just by what you know in HEMONC. He has multiple issues, and you need help from people from various specialities. You also need people from allied health professionals team, like the nutritionist, the physiotherapist, the counselors. So it's all about having a huge team. They say it requires a village to treat a patient with cancer, and that is totally true. I mean, I agree with it totally. So even if you're treating one patient or 10 patient or hundreds of patient, the number of people involved is going to be huge. You have to have at least 15-20 personnel who are doing their own job and trying to take care of the patient's need and the family's need. So that is true about the HEMONC BMT, treatment, how you go about treating patients. And therefore you need to have a working environment of harmony. You need to have leadership skills. You need to be able to form a team, or get into a team, and your presence should make the team stronger. So you should be of that personality. So I was privileged to actually have the first exposure to HEMONC through Dr. M.B. Agarwal as a student in Sion Hospital through his lecture series, and they were really inspiring, I should say. Then then I had the privilege of actually learning pediatric hematology, oncology from the founders, and of primary immunodeficiencies from the founders like Dr. M.R. Lokeshwar and Dr. Zeenat Karimboy, which was very inspiring. And I'm fortunate for, the continued guidance that I'm getting at the center where I work from my mentor, Dr. Manglani, whom I joined immediately after my postgraduate program, because that time we didn't have any structured HEMONC program in pediatric hematology oncology. So though I was keen on intensive care, I realized that HEMONC gives everything. It gives you the challenging cases that you want to deal with, including the intense nature of intensive care setup, the critical care setup. So the future seems even more exciting for people of our age group and the youngsters who are going to come, because there is so much of advancement happening in transplant techniques, better understanding of immunology, immunogenetics, oncogenetics, inborn errors of immunity, and fascinating modalities of therapies like immunotherapies. You have cellular therapies coming in. And there are newer molecules even for benign hematology conditions like thalassemia, hemophilia. So I'm sure we are going to end up giving a good quality of life to our patients, and that is most important. So the field is vast, and we are already seeing a lot of bifurcations within the field because people are working in focused areas within the field also, based on their areas of interest like neuro-oncology or hematolymphoid or solid malignancies or just transplants. So there is scope for everyone to grow in this field. You just need to have the right mindset, I would say. What one needs to be is sincere in continuing to learn, basically. That means should be ready to be a student all your life and genuinely care for your patients and their quality of life. Because decisions at every step, in hematology, oncology, you have to actually think whether this is going to improve the quality of life. Because if this drug is available, you have to actually know whether this is going to actually improve the quality of life of patient, because certain conditions are chronic. So you have to be sure about that. And while you do this for your patients, you also need to take care of your health and wealth, I should say, because no one taught us what is going to be the graph like.
Ma'am,
So
sorry to interrupt, ma'am, because we have got lecture again. So if you can please sum up your
yeah,
talk.
I'm just trying to say that you have to work in such a way that you can balance it out in this field. You need to be you should not be left searching time for yourself, for your family, for your hobbies, and this can happen only if you work as a team. So build a team, and you remain grounded, and that's all that you require, because a lot of it teaches you everything about life, this field, and in a philosophical way also. And you really need to understand what your journey is going to be like in this field. So yes, the youngsters, I would just say, come join us, experience the fascinating ride of hematology, oncology, and transplant. We have a lot of things to do. Both clinicians and researchers can make a difference in this field. Thank you so much.
Thank you so much, ma'am, for that great words of wisdom. I think everybody would be benefited, all the students, all the audience, all the delegates here. Thank you so much, ma'am, for that.
My pleasure.
Now we have our guest speaker for the day, Dr. Aisha Sunawala from Mumbai. Dr. Aisha Sunawala is DNB Medicine and FNB in infectious disease. She's an infectious disease specialist at PD Hinduja Hospital and Medical Research Center, Mahim, Mumbai. She's a consultant, Division of Infectious Disease at PD Hinduja Hospital, Jaslok Hospital, and Bridge Candy Hospital, Mumbai. Head the National Board Accredited Infectious Diseases Fellowship Program at PD Hinduja Hospital, Mumbai. Also, she is Secretary, Antimicrobial Stewardship Committee. She is a mentor and course coordinator, Hospital Fellowship in Infectious Diseases and Antimicrobial Stewardship. I invite her to deliver a lecture on vaccinations in hematological diseases. Over to you, ma'am, for your lecture. Thank you so much.
Thank you so much. Thank you for that introduction, and a big thank you to Dr. M.B. Agarwal for inviting me here today. So I'm just loading my slide. So as our chief guest so aptly summed up, that the field of hematology, hemato-oncology is dramatically growing, advancing. It's very exciting. There are new modalities for diagnosis and treatment. And that needs to go hand in hand with a holistic approach to these patients. And as she pointed out, a holistic approach would involve team effort, and a team effort would also involve prevention of infections and precautions in these patients. Because at the end of the day, once they leave the sanctity of our protected environments in our transplant centers, we put them back out into the community, back out into the same geographic, same social, same economic factors that they will be exposed to, and that we need to keep in mind. So I'm going to spend the next 30 or 40 minutes discussing optimal immunization in the hematology population. And I must start by telling you that this is not something that is very well defined. Again, it's a subject that's constantly changing. There are a lot of new advancements, a lot of studies, a lot of excitement in terms of new developments, and a lot of uncertainties. But let's see what we know and what we can make of it. So this is what we're going to cover. We're going to cover We're going to cover mechanisms of immune activation and types of vaccines. Just a brief on that. The spectrum of immunosuppression and susceptibility to infection. Principles of immunization in the immunosuppressed host. Then we're going to look at specific risk groups in hematology and impact studies in various risk groups. So we understand that immunization exploits the complex, highly evolved human immune system to respond to and recognize and remember antigens that have been sort of introduced or exposed. And even in the relatively immunocompetent host, we know that the immune system, our understanding of it is really very primitive. It's just the tip of the iceberg. Even among a relatively immunocompetent population, each individual, even in the same family, responds so differently to different viral or bacterial exposures, different vaccines. And so you can imagine what might happen in the population whose immunity has been weakened or destroyed due to something. Needless to say, the impact of vaccination is undebatable. And you can see in our country over the past 40 years, just with our own childhood immunization program, the dramatic impact that vaccination has had on the most important vaccines that have been introduced. So if I talk a little bit about mechanism of immune activation of the vaccines, we know that when a vaccine is introduced, either subcutaneously or into the muscle, there are certain danger signals which are present in the adjuvant of the vaccine. The adjuvant of the vaccine acts as an immune enhancer, all right? And this produces danger signals that attract pattern recognition receptors on circulating dendritic cells. The circulating dendritic cell then carries the introduced antigen to the draining lymph node. At the level of the draining lymph node, the major histocompatibility complex acts as antigen presentation to the CD4 T cell or the helper cell, with the help of which it activates circulating soluble B cells. So this is T cell dependent B cell proliferation, activation. And when it proliferates, we initially have differentiation into circulating plasma cells, which are short-lived. But these plasma cells are what are responsible for the initial response to a vaccine, the initial antigenic boost that you see in the first few weeks after vaccine introduction. Unfortunately, they're not long-lived. The long-lived B cells actually form niches in the bone marrow, where they are then recounted when there is a future antigenic exposure. The CD8 cells, on the other hand, are responsible for elimination of the protein antigens or the foreign antigens. So this is a very simplistic sort of overview of immune activation with vaccination. If we were to look at the types of vaccines broadly, live vaccines, and these are most of the live vaccines that sort of are available to us today, are administered subcutaneously because in the subcutaneous compartment, the vascularity is relatively poorer, and vaccine uptake happens over a prolonged period at a relatively constant rate. So it acts like a depot. On the other hand, killed vaccines, whether they are whole organisms, toxoids, subunits, virus-like particles, are generally administered intramuscularly, where the vascularity is much higher and the vaccine efficacy or the immunogenicity is produced within a much shorter period of time than the live vaccines. So when we talk about the killed vaccines, we must remember that you have polysaccharide vaccines, which are of low immunogenicity. And we know that that immunogenicity can be augmented by conjugating the polysaccharide with another protein carrier or another protein antigen. And I'll come to that in the next slide. So the protein polysaccharide conjugate vaccines are the ones which actually have augmented immunogenicity. And these are the ones that are superior in the immunosuppressed host. And I will reiterate this in the course of my talk. We now have new viral vector vaccines, most important being our Covishield, the nucleic acid vaccines, which everyone's talking about, the mRNA vaccines, the Pfizer and Moderna COVID vaccines. and a whole lot of other things that are still in the pipeline or experimental to date. But a lot of exciting options coming up there as well. As I explained earlier, the state of immunocompetence itself is debatable. But we know that when immunocompetence is altered, we have a varied spectrum of individuals, ranging from a healthy pregnant lady to a diabetic to immunosenescence. And we know that immune deficits in these patients are vastly different from that you'd see in a transplant patient or in a chronic kidney disease patient or in a patient on active chemotherapy or a hematological malignancy for that matter, which is why it makes it very difficult to categorize these as immunosuppressed hosts and sort of direct protocols to the entire group as a whole. So this is a very simplistic cartoon again, which attempts to go a little further into that. And based on the immune arm that is affected, it looks at which conditions are associated broadly with which immune defects and what they might produce. So if we were to look here, solid organ transplants, patients on steroids, neutropenics, MDS, AML, allogenic HSCT, all have predominant neutrophil macrophage dysfunction, which predisposes them to the invasive mold infections, nocardiosis, mycobacterial infections, as well as systemic viruses, toxoplasma, as opposed to patients who are solid organ transplant, T-cell leukemias, other forms of chemotherapy, biological agents, which would predispose them to predominantly T-cell pathogens like you see in HIV. And then you have the patients who are predominantly hypogammaglobulinemic or with B-cell defects, predisposing them predominantly to the encapsulated bacterial organisms. Again, I call this a simplistic cartoon because these are not watertight compartments. Each of these patients will have very diverse immune deficits, of which our understanding is elementary, and they're dynamic. They're in a state of, they're not in a state of flux, they're extremely dynamic. So based on where in the course of the disease, what treatment, what prior comorbidities, the age of the patients, these things can vary significantly. And that needs to be kept in mind. But if I was to try to put together some common principles, and I started with that net state of immunosuppression being dynamic, it's important to then reassess the status of the patient at every visit. Is there a relapse? Is there chemotherapy? Is there augmented immunosuppression for any reason? Does the patient have graft rejection, GVHD? Patient received IVIG recently, biologicals, any recent CMV disease, opportunistic infections. And based on this, one needs to categorize and recategorize an individual into high-level and low-level immunosuppression at every visit. And I'll come to why this is important. So live attenuated vaccines, as we all understand, this is a black and white rule, are contraindicated in pregnancy and high-level immunosuppression. Precautions need to be taken to caregivers and household members of immunosuppressed patients who are given live attenuated vaccines. We'll discuss this in greater detail. So let's look at our high-level immunosuppression. Who are we looking at? The HIV population with a CD4 T-cell lymphocyte count less than 200 or any other T-cell defect that would predispose to a T-cell count which is low. Systemic corticosteroid therapy of more than 20 milligrams per day, that is the equivalent of prednisolone, more than 20 milligrams per day for over 2 weeks. Biologicals, including TNF-alpha inhibitors or anti-CD20. Patients who are actively receiving chemotherapy, less than 2 months since a solid organ transplant, patients with combined primary immunodeficiency disorders, or hematopoietic stem cell transplants, autologous and allogenic would all come into high-level immunosuppression. Low-level immunosuppression are the same variables but with different sort of values over here, converse from these. And based on this, the live vaccines are, if we look through our list of sort of readily available live vaccines that we do use, apart from the live influenza vaccine, the yellow fever vaccine, and the cholera or the oral typhoid vaccine, not the intravenous typhoid vaccine, the conjugate typhoid vaccine that is now available to us, but the earlier oral typhoid vaccine. These are the 3 or 4 vaccines that are an absolute no-no, regardless of the level of immunosuppression. So whether it's high level or low level, patients should not receive a live influenza vaccine, yellow fever, cholera, or typhoid. There is a caution here in yellow fever. CD4 count, which is between 200 and 500, you may consider it. Again, caution in infants, more than 60 years pregnancy. And it's actually mentioned that unless it's absolutely necessary, travel to areas where there is yellow fever should actually be discouraged in patients with high or low level immunodeficiency, because this vaccine is not to be given. Another important thing to remember is that if we're using the varicella vaccine or the MMR vaccine for our patients, it should never be the combined vaccine of MMR-V, because this contains 7 times the antigenic strength of varicella in the combination vaccine, as opposed to the single antigen varicella vaccine, which is available as an isolated vaccine. So in the high-level immunosuppressed host, it should be only the isolated vaccine and not the combination vaccines that come for pediatric age group. Strategies to improve vaccine immunogenicity. There are several that have been tried and are still under study. Conjugate vaccine use of T cell, because as I explained earlier, when you conjugate a polysaccharide with a carrier protein, you change the immune mechanism to a T cell dependent mechanism, which I showed you in the initial diagram, which is a long lasting immunity, as opposed to one induced by a polysaccharide, which is a relatively short lasting and relatively lower immunogenicity. So examples of these are the pneumococcal conjugate vaccine, which is available as Prevnar 13 or 10 in our country, 15 and 20 in the West, versus the pneumococcal polysaccharide vaccine, which is available as Pneumovax 23. Higher antigen dose, double the dose of recombinant HPV vaccines have been tried successfully in chronic kidney disease and transplant patients, and they've actually found through serological studies that the vaccine uptake is better if you use double the dose in these patients. You can actually even reduce the duration of sort of the entire duration of the 3-dose vaccine. Adjuvanted vaccines. So as I explained earlier, adjuvants in the vaccine act as immune enhancers. And especially for the Hep B vaccine, you have a Hepislav B, which is combined with a novel immunostimulatory sequence, which acts as an adjuvant and may offer superior seroprotection in certain risk groups. Unfortunately, this is not yet available in our country, but used very widely in the West. What about the timing of the vaccine? So inactivated vaccines, by and large, I mean, if we were to go by a ballpark rule, inactivated vaccines should be given more than or equal to 2 weeks prior to cytotoxic chemotherapy, biologicals, or pre-transplant conditioning. Live vaccines for the same prototype of patients should be given more than 4 weeks prior to any of these therapies. Anti-CD20 therapy is an exception, and more than or equal to 6 months is recommended between the last rituximab dose and vaccination. We know that CAR T-cell therapy results in prolonged B-cell aplasia and hypogammaglobulinemia, and it's expected to affect vaccine efficacy. However, we don't have exact data or very robust studies to tell us to what extent this would be affected or how we could extrapolate it. IVIG does not interfere with inactivated vaccines. However, it should not be administered for patients who are receiving live vaccines like MMR and varicella for at least 8 to 11 months prior to and 2 weeks after MMR and varicella vaccination. So live vaccination, IVIG needs to be kept in mind. Ring vaccination is a very interesting and a very important concept in vaccination of the immunocompromised host, because it protects the host who cannot receive the vaccines or who has attenuated responses to the vaccines. And ring vaccination is nothing but appropriate, adequate vaccination of the family members, the caregivers, the close contacts of the immunosuppressed patient. So all inactivated vaccines must be given to household members and caregivers. For example, the inactivated influenza vaccine, Tdap, all the childhood vaccinations of children in the house which involve inactivated vaccines should go on regardless of sort of any level of immunosuppression. Live vaccines, of course, we know are to be given with precaution. So if one must give a live influenza vaccine to a caregiver or a household contact, you need to isolate the patient for 7 days. If in close contact with an HSCT recipient less than 2 months, patient who has graft versus host disease, or somebody with combined immunodeficiency, severe combined immunodeficiency. The zoster vaccine, live zoster vaccine, avoid contact if the caregiver develops rash. And for mothers, immunosuppressed mothers of children who are given the oral rotavirus vaccine, they should avoid handling the diapers or stools of children for at least 4 weeks. However, for both these, we have options for inactivated vaccines now, and those are definitely a preferable sort of option. Let's move on to specific risk groups in hematology. So if we were to start with splenectomized, whether they are structurally or functionally with hyposplenism, hemoglobinopathies, primary complement immunodeficiencies, we know treatment with eculizumab can lead to terminal complement inhibitor deficiency. And all these predispose to encapsulated bacterial infections, which are your strep pneumonia, Neisseria meningitis, and H. influenza. Eculizumab, interestingly, only affects the terminal complement inhibitors and predisposes predominantly to meningococcal, but not to pneumococcal infection. So these are sort of prototypical. This is the one that we employ. I've tried to sort of tabulate it for you, but this is what we would use. And these are compiled from various guidelines. This is a very good, this article by Whitaker et al. Sums up the guidelines over the past 10 years very well in the immunocompromised adults. And I encourage you to go through it. It's a very well-written article. So pneumococcal, both the conjugate and polysaccharide vaccine must be given more than 8 weeks after the conjugate vaccine. And if by any chance the conjugate vaccine is given, or the polysaccharide vaccine is given first, I beg your pardon, the conjugate should be followed a year later and not earlier than that. Important to remember for all these vaccines in splenectomy, you have to sort of look at whether the patient, you have to actually try to give these patients elective vaccines prior to splenectomy. And anything more than 2 weeks prior to splenectomy is what is recommended for all these vaccines. Post-splenectomy, again, you'd need to wait post-splenectomy for at least 2 weeks in case of an emergency splenectomy. A single booster dose of the pneumococcal polysaccharide vaccine has been recommended after 5 years. And for the meningococcal vaccine, booster doses every 5 years are recommended, especially in areas which have high prevalence of meningococcal disease. We don't really come into those areas, which would be more of the Middle East and some parts of the Western countries, especially. But anybody who's at high risk in terms of community living, college graduates living in a hostel, sort of military inmates, prison inmates, all of those should receive the meningococcal vaccines very strictly. The Men-B vaccine is also recommended for this cohort of patients, but unfortunately, it's not available in our country. Important to remember that Menactra, not Menevo, one of these conjugate vaccines has been found to have a lower efficacy when given together with the conjugate pneumococcal vaccine. And so this should be separated by 4 weeks. And that also needs to be kept in mind when you're vaccinating these patients either prior to or post-splenectomy. Moving on to primary immunodeficiency states. Again, each one is quite different from the other. And I've just tried to bring out the salient points with respect to the broad categories of primary immunodeficiency states. So for primary complement deficiency, there are no contraindications to any vaccine, and it should be as per the schedule of the splenectomized patients that I just showed you in the slide before this. Phagocyte cell deficiencies, BCG, oral typhoid are contraindicated in all phagocyte cell deficiencies. All other live vaccines may be given in chronic granulomatous disease patients only. Live vaccines are contraindicated in patients with leukocyte adhesion defects and geriatric gastritis. Cytokine and cellular activation defects, including interferon gamma and interleukin 12 axis defects, all the live vaccines are contraindicated once again. Minor antibody deficiencies, all vaccines may be administered except for the oral polio vaccine. You may give the killed IPV or the injectable polio, but the oral polio is contraindicated, especially to the IgA deficiency population. Major antibody deficiencies, all live vaccines are contraindicated, and one must remember to avoid any vaccine during IVIG treatment except for the influenza vaccine, which is found where the benefit is found to be more than the risk. Combined immunodeficiencies, live vaccines are contraindicated for severe combined DiGeorges with a CD3 T cell less than 500. Other combined immunodeficiencies like Wiskott-Aldrich or X-linked lymphoproliferative disease and familial disorders which predispose to HLH. Again, these are all from the practice updates. And this is another sort of IDSA practice update which follows the 2013 guideline. What about principles in the Hemat-Onc group? We know that serologic responses may be best when given between chemotherapy cycles, more than 7 days after the last treatment, or more than 2 weeks before chemotherapy starts. Needless to say that clearly the best sort of the window or the greatest window is before chemotherapy starts. But it's important to remember that immunizations administered during cancer chemotherapy are generally not counted as valid as per serological studies and studies of efficacy, unless there has been evidence of seroprotection that can be determined by a laboratory assay. So by and large, these vaccines should be repeated at a later time to increase vaccine efficacy if you have no ways to measure seroprotection. The IDSA recommends inactivated vaccines 3 months after completion of chemotherapy to maximize vaccine immunogenicity, and live vaccinations are contraindicated during chemo, of course, and for 3 months after. So ideally, 3 months after is the time when you're going to have improved immunogenicity and efficacy. But if that has to be given, it's more than 7 days after the last treatment or more than 2 weeks before chemotherapy starts. Moving on to myeloid malignancies, although seroconversion rates to 1 dose of inactivated influenza vaccine are low, yearly vaccination is recommended, and especially after the end of chemotherapy, as long as a patient is considered to be immunocompromised. We know that the inactivated influenza vaccine is a universal vaccine. And so even beyond the hemat-oncology group, this is a vaccine that is recommended for all adults, especially adults who have comorbidity or who are over a certain age. In India, we consider that age as 50. There's no significant benefit of a higher or a second dose as per studies that have been done. I'll show you some studies with variable results as we go on. Immunity loss is lower in children who have AML than with ALL, but revaccination with a booster 3 to 6 months after the end of chemotherapy usually restores seroprotection for most of the kill vaccines. And treatment of CML with tyrosine kinase inhibitors was associated with an increased risk of infections, including TB, varicella zoster, and HBV reactivation, which needs to be kept in mind. And so keeping these broad principles in mind, this is a busy table, but one that's present in the SL7 guidelines, which appeared in the Lancet in 2017. And these are the most recent guidelines for vaccination in the hematology group. So again, they predominantly stress on the inactivated influenza vaccine, the pneumococcal vaccines, and the HBV vaccine in places where, in geographical areas where HBV is high risk, or patients who are transfusion dependent and who have high risk of HBV transmission or reactivation. We must remember that the expected response rate to dasatinib or bosutinib treatment might be lower than with other tyrosine kinase inhibitors, and there's no data on ruxolitinib. So these are still emerging, and still to be studied. What about lymphoid malignancies? Lymphoid malignancies really represent a very wide heterogeneous group. And on one hand, you have aggressive lymphomas, which require prompt intensive chemotherapy, and vaccination seems almost futile at this time. On the other hand, you have patients who obtain remission, and then they may no longer be at high risk of infections, except for those who've received anti-CD20 rituximab. So the opportunity should be seized in patients with indolent lymphoma who don't require immediate treatment. And that is the window that we actually use to vaccinate these patients if it's feasible. We do know the lymphoma are at an increased risk for severe forms of influenza and have a 5 to 10-fold increased risk of invasive pneumococcal disease. So this was an important risk factor in them, and influenza and pneumococcal are really the most important vaccines in this cohort of patients. What about the chronic lymphoid leukemias? High incidence and severity of pneumococcal and Hib infections. They have a 30-fold risk of invasive pneumococcal disease compared with the general population. And as per this study, of 263 patients, including 66 CML patients on ibrutinib, the incidence of infection was 72%. Death was seen in almost 40% of these patients. Response to inactivated influenza vaccines is usually very low, 5 to 30%, except in treatment-naive patients. Again, reiterating the need to vaccinate them before any treatment has been started and before they become more and more immunosuppressed. Multiple myeloma is another very important risk group, and these patients remain at high risk because of the wide spectrum of immune dysfunction, B cell, T cell, natural killer, dendritic cell, with a hazard ratio for infection of 7.1. And studies have shown us, studies from Asia as well as northern parts of Europe, showing us that a fifth of the deaths in multiple myeloma are due to infections, and some of them vaccine-preventable infections. They're 4 to 14 times more likely to get herpes zoster, especially when they're on bortezomib. They have a 6-fold higher risk for influenza, and extremely variable seroconversion rates from 0 to 83%, mostly between 20 to 25%. And there's been found to be no clear benefit of a second dose in the same year. Patients with multiple myeloma are 60 times more likely to get pneumococcal disease than the general population. And response rates to both conjugate as well as polysaccharide vaccines in one of these studies was about 60%. I'll show you more. So again, in the lymphoid malignancies, the important vaccinations are the influenza, pneumococcal vaccines, other inactivated vaccines depending on risk factors, geography, epidemiology, human papillomavirus vaccine, which is an important thing in the lymphoma group, especially in the HIV population and patients with multiple sexual partners. It's anyway recommended for all healthy adolescents and young adults now, but this group is particularly vulnerable and it needs to be kept in mind. Moving on to the hematopoietic stem cell transplant patient. And I mean, it would be foolish of me to teach this to the hematologist, but it's more just for a quick recap and an understanding. But we understand that the immune recovery post-transplant is dependent on various factors. And although this is sort of what is expected to happen, neutrophil recovery beginning at about 14 days, followed by dendritic cells, non-killers, monocytes, which take longer. B cells, which come up by about 100 days post-HSCT, with CD8 cells also expanding earlier. But the CD4 cells actually taking the longest time and recovering almost after 2 years post-HSCT, with a prolonged CD4 to CD8 reversed ratio that sort of remains for several years post-transplant. But we understand that this diagram is really affected by so many factors, right from the pre-transplant period, the recipient's vaccine immune status, some degree of the donor-derived immunity, age, underlying diseases, prior treatments, to transplant factors like underlying malignancy, prior chemo, type of conditioning and myeloablation, the type of transplant, and then post-transplant interventions, the immunosuppression, donor lymphocyte infusions, GVHD, other post-transplant events and infections. All these play a huge impact in this immune recovery. And so none of these, it's very difficult to cohort these patients into a single prototype. Nevertheless, because we haven't really been able to, differentiate them, and for the ease of administration and simplicity, this is practically what we would follow post HSCT, both allogenic as well as autologous, for the inactivated and the live vaccines. So the inactivated vaccines, we would start at about 6 months post-transplant, except for inactivated influenza. If there's an outbreak in the community, you can give it as early as 4 months post-transplant. There have been some randomized control studies to show that responses to pneumococcal conjugate vaccine may come as early as 3 months, but we still follow a 6-month protocol. And live vaccines are introduced only after 2 years. So this would be our criteria for starting inactive vaccines, and I've just put up our checklist. Completed at least 6 months post bone marrow transplant, not receiving chemotherapy, no IVIG in the past 2 months for inactivated vaccines, not received rituximab in the past 6 months, no evidence of moderate or severe graft versus host disease. And if all the above criteria are satisfied, we may begin with inactive vaccines. Sometimes we begin with inactive vaccines even when the patient is on chemo or has received rituximab or has some degree of graft versus host disease. After counseling the patient, that vaccine response may be suboptimal, and there may be a need to revaccinate once therapy is over. And so understanding that even minimal protection may be better than no protection, we go ahead with vaccination. What about live vaccines? Only after completion of 2 years post-transplant, no immunosuppressive therapy for at least 1 year and at least 8 months after receipt of IVIG. So I've just put up our vaccine schedule. So for example, if you had a bone marrow transplant on the 1st of January 2016, we enter in the patient's date, and then we give them a sheet like this where we put in the dates of the various vaccines that they will be receiving. And as they receive it, of course, they have an immunization card, just like the one we provide in pediatrics to children. And it's ticked off over here, and the vaccine details are entered onto their immunization card. So this is our protocol, and this is what we follow at Hinduja Hospital. Moving on to impact studies in this population. And again, as I said, impact studies are very difficult to determine because this is a heterogeneous, dynamic population with very different risks and sort of rapidly changing risks. So when you look at impact studies of vaccination, you look at clinical efficacy, which is the decreased frequency or severity of the disease in vaccinated patients as opposed to non-vaccinated patients. You may have seroconversion studies where a vaccine-specific antibody, this is a qualitative study. So you look for the vaccine-specific antibody in a seronegative patient, or you look for a 2 to 3-fold rise, predefined rise, increase in patients who are seropositive. And then you have seroprotection studies, and these are more quantitative. That was qualitative, this is quantitative, because there is a minimal vaccine-specific antibody titer that you're looking at in the estimated clinical, for estimated clinical protection of at least 50 to 100% in the population that you're studying. So if we were to look at influenza vaccine, various studies have looked at high dose versus low dose, 2 doses versus single dose, 4 weeks apart, non-adjuvated versus adjuvated. And they haven't really found very significant impact of any of these manipulations on the vaccine. So there was slightly higher or significantly higher protection for H3N2 when you used a higher dose, but not really for H1N1 or influenza A or B viruses, which are the most important. What about 2 doses given 4 weeks apart? There was no real significant difference for either H3 or H1N1. And the most important sort of factor that they noticed was time from transplant. So the longer the time post-transplant, the greater was the efficacy of the vaccine. And they also found that the vaccine efficacy, despite everything, was highest in the pre-transplant recipient vaccination group, and that lasted even post-transplant. So the importance of vaccinating your patients before they undergo any immunosuppressive therapy. Based on a meta-analysis of all these studies, what they have come up with is that standard inactivated influenza vaccine is recommended for solid organ transplant. For hematopoietic stem cell transplant, they feel that high-dose trivalent influenza vaccine may have greater immunogenicity only for the H3N2 strains, but we're still using the regular dose as per guidelines. For malignancies, by and large, they found a greater fold increase to influenza B antigens in the leukemia group and H1 antigens in the solid tumor group. So these are, very sort of very small impact on just a certain part of that group, and that hasn't really changed guidelines. So we still just go with the recommended immunization schedule, that is annual influenza vaccination in these patients. Let's look at pneumococcal disease. I think the greatest studies across different populations have been done on pneumococcal disease, and most of this data comes from Northern Europe, the Swedish, the Danish, and the Dutch registries, where they've looked at thousands and thousands of patients, and the entire registry, the entire national registry of patients that was vaccinated. So based on those studies from this, Danish registry, they found that invasive pneumococcal disease was 13 to 50 times higher, the incidence in the hemat malignancy population, and accounted for approximately 10% of all invasive pneumococcal events in adults. And you can see that when we look at time since malignancy, I'm sorry that this has gotten blanked out, but these are the hematological malignancies, multiple myeloma, CLL, and non-Hodgkin's lymphoma. And you can see that the risk for invasive pneumococcal disease remains high despite the time since malignancy, as opposed to non-hematological or solid malignancies, which is depicted over here. So much higher risk, and risk that remains sustained over time. And so from the same Danish nationwide study, adults with hematological malignancy were found to have a 39-fold increased risk of invasive pneumococcal disease. They found this is a very, very important objective of this study, and perhaps exemplifies how significant the public health impact of vaccination is. So 3.5% annual decrease in incidence of invasive pneumococcal disease in the adult population with the introduction of PCV as childhood vaccination. We know that pneumococcal conjugate vaccine not only prevents invasive pneumococcal disease, but it also prevents nasal carriage or colonization, thereby inducing herd immunity. And so this is probably the greatest impact, that you vaccinate one individual and that has repercussions for the entire population at large. But the decrease in IPD incidence when this vaccine was introduced into the childhood immunization schedule in Denmark was far more pronounced, and they found a 9% reduction in incidence of invasive pneumococcal disease in the hemat malignancy group. Vaccinated multiple myeloma patients had lower incidence of IPD compared to unvaccinated, but they didn't really find this in the other hemat malignancy groups. So direct vaccination of the immunosuppressed patients didn't really amount to as much as indirect herd immunity, which was offered by vaccinating the community or children in the community. Zoster inactivated vaccine is not here yet, but it's a very promising vaccine, and we're expecting it by mid next year. It's already available in the West, and GSK has already started talking about it and discussing it among circles in the country. So this was a study done on over 5,000 adult patients with solid tumor malignancies receiving chemotherapy versus hematological malignancies, either on or off chemotherapy. And these patients were randomly assigned 1:1 to receive 4 doses of varicella zoster inactivated vaccine versus placebo, given 30 days apart. The estimated efficacy in the solid tumor malignancies was 63%. So anything between 50 and 100% is acceptable vaccine efficacy. But the hematological malignancy arm was actually terminated early because they found that it was futile. The efficacy was just 16.8%. 2-dose course of recombinant zoster vaccine reduced the incidence of herpes zoster in autologous stem cell transplant recipients, interestingly, in this study. However, they have found that there's been a discordance with regards to this vaccine between immunogenicity and clinical efficacy. So the serological studies and the clinical efficacy studies don't really match up. But this is a relatively new vaccine. Prior to this, we only had Zostavax, which was the live vaccine and which was contraindicated in these patients. This vaccine is called Shingrix. And as I said, it's expected sometime next year. It's a promising vaccine, but still we need more information about the hematological malignancy arm and perhaps more information on HSCT population as well. So if I could take you back in time to this famous scientist, Edward Jenner, and his work on smallpox and cowpox way back in the late 18th century. We had anti-vaxxers as far back as then, and here you can see how they actually, artists drew pictorials of how you would mutate if you allowed Jenner to go about his work and vaccinate the population at large. And here you can see people with hideous mutations on their faces and their bodies. And then there were these very strong anti-vaxxers who went throughout the countryside proclaiming that the vaccine givers or the scientists were actually doing experiments and, causing more harm, and it would affect the population in the future. Nothing seems to have changed in 2020. This is where we stand. And surprisingly, among my patients, the most vociferous, or perhaps understandably so, but the most worried about taking the COVID vaccine were the immunosuppressed population, or the population that really was at the greatest risk of having complications of SARS-CoV-2 infection and having severe disease due to this infection. And it took a lot of understanding on our part, a lot of sort of reading into the vaccines. These were all new vaccines, new platforms, mRNA vector based. There was a lot of discussion even among the ID groups whether we could really call these 100% killed vaccines or not initially. But until we had data, the initial months were difficult to convince, and there were times when we actually were wondering whether we should hold off and do ring vaccination for these patients as well. So we now have large studies, huge systematic reviews and meta-analysis coming out from the immunocompromised patients. And you can see this meta-analysis looked at various studies across different immunocompromised groups: solid cancers, hematological, immune-mediated inflammatory disorders, HIV, organ transplants, etc. They looked at first dose vaccine, second dose vaccine, various countries from across the world. Unfortunately, most of them Western countries except for South Africa and all, but no studies from our country. And they looked at both vaccine types, the mRNA as well as the non-replicating viral vector, which would be our Covishield and Covaxin is our inactivated vaccine. So they looked at all three vaccine types especially. And if I could just simply show you the forest plots, everything on the left favors healthy controls and everything on the right favors immunocompromised patients. So you can see after the first dose of vaccine, clearly there was a much better response in the healthy controls as compared to the immunocompromised patients, with barely a single one of these variables on the midline or crossing the midline. But you can see how that improved after the second dose of the COVID vaccine. And this was across the board. I said all COVID vaccines, whether they were mRNA or viral vector. You can see that the second dose of vaccine definitely centered this forest plot more than the first did. indicating that perhaps a complete vaccination schedule, including a booster dose, would go a long way in protecting these individuals. Fortunately for us, the COVID strain also changed. I don't know what it would be like if we still had something as aggressive as Delta. But clearly with Omicron, we've seen enough patients, even in the highly immunosuppressed group, doing very well. So it's difficult to say how much impact the vaccine has had and how much the changing serotype of the virus has had. But nevertheless, I think that it's important now for us to understand that this group is particularly vulnerable and must be vaccinated. Another study here showing us that within this group, the myeloid malignancies actually did much better. You can see much better sort of serological titers in the myeloid malignancy group as compared with the lymphoid. So the lymphoid, quite a few of them, almost 20% of them having titers less than 7 BAU per ml. And the allogenic stem cell population, of course, was the poorest. The myeloid malignancy did well regardless whether they were treatment naive or on treatment, as opposed to the lymphoid malignancy. This is a study, again, a recent study, but a single study. In general, active immunosuppressive treatment is associated with lower anti-SARS-CoV neutralizing antibodies, as with any other vaccine. Improved antibody response is demonstrated while vaccinated at least 6 months after the end of chemotherapy or stem cell transplant, like it is with other vaccines. For anti-CD20 recipients, they actually found antibody responses improve significantly only after 12 months. And better antibody responses with higher titers were seen in patients receiving mRNA versus viral vector vaccine, which is not surprising because even in the healthy cohort, these patients, or not the patients, but the population who received mRNA in the Western countries definitely had higher titers than the viral vector vaccine. However, we know that these were not long-lived and they've all required several boosters as well. So if I can leave you with a take home, once again, our understanding of the immune response to infection and immunization in the immunosuppressed host is particularly elementary. The net state of immune competence is fragile, dynamic, and can never be a watertight compartment. And so each individual needs to be taken in light of his or her risk factors at that particular point in time. Awareness and understanding of the principles of immunization in this population are essential before you start out. And one must attempt to seize that window of opportunity to immunize prior to treatment commencement in these patients. And the holistic aim should be to optimally vaccinate all healthy children and adults in the community in close contact with these patients to offer herd immunity and bring immunization. So I'm going to leave you with that and take any questions if there are any.
Thank you so much, ma'am, for that wonderful lecture. You were excellent and fabulous.
Thank you.
Completed entire aspects of vaccinations, everything, lymphoma to leukemia, everything was covered in vaccination. Thank you so much. It was an excellent lecture.
Thank you.
You've got some Indian colleagues now who are going to bother you with all the questions.
I hope I can answer them, but I'll attempt to.
So I would request all the discussants first to please use the raise hand signs. If you've got any questions, we can start off with fine. So we all got the question first. Dr. Deepanjan Haldar, your question, please.
Hi, thank you. It was an excellent lecture. My question is regarding the IVIG. Can you hear me?
Yes, I can hear you.
My question is regarding IVIG. So often like post-transplant, we see certain hematological malignancies, patients who are immunologically suppressed, the IgG level is low. So we keep giving monthly dose of IV immunoglobulins. So I saw you mention in one of your slides that patients who are on IVIG, the vaccination needs to be avoided. So two parts of the same question, any particular reason for that? And so what is your strategy for these patients? Because these are the really most vulnerable group.
No. So if I could clarify, IVIG, inactive vaccines are not contraindicated with IVIG. Okay, so your killed vaccines or your inactive vaccines should go on regardless of IVIG. Again, with the understanding that they may not produce effective antibodies or optimal antibodies, and you may need to revaccinate after you've completed treatment. So that counseling to the patient should be given. And what we generally tell them is that there is a risk-benefit ratio. There's a benefit ratio over here of giving some minimal protection rather than giving none. On the other hand, live vaccination in patients with IVIG is contraindicated. And it's said that you need to wait for at least 8 to 11 months post IVIG, because you would definitely neutralize. If you were to give IVIG post live vaccination, you would neutralize the vaccine titers. Okay, so you're really going to produce no effect.
Thank you.
Thank you, Dr. Dipanjan, for that question. Dr. Nishad, your question, please.
Ma'am, that was a wonderful lecture, quite enlightening and educating. I have two questions. The first is, we treat a lot of pediatric acute lymphoblastic leukemia. So in these patients, their vaccination schedule is interrupted. Some of them complete their vaccination, but some of the vaccination schedule is interrupted and they get acute lymphoblastic leukemia. So wanted to know, some guidelines recommend only the booster for patients who have completed their vaccination, whereas some guidelines recommend the whole schedule. So what is your opinion about this?
Right. So it actually depends on the individual child and how far that child has got with that respective vaccine. Yeah. So for certain vaccines, which you can actually check serological responses to, you may only give boosters. For other vaccines where you have started out and you haven't been able to really complete it, you may give an entire course again. Okay, so when we're talking about the pneumococcal vaccine, when we're talking about hepatitis B, where you can actually check serological responses, you may not need to repeat the entire vaccination series. Yeah, again, DTaP and things like that, you may get away with just a booster. But yes, you're absolutely right that there are some recommendations which are contradictory and say that you need to, restart the entire vaccination process. I'm not a pediatrician, honestly, so I don't vaccinate this age group often. But my understanding of it is that if they have been adequately vaccinated prior to starting chemotherapy and it wasn't done during the course of chemotherapy, they may get away with just a booster rather than repeating the entire course.
Thank you, ma'am. My second question is about lymphoma and myelomas. So as we understand, after rituximab, there should be a time gap of about 6 months. But the myelomas, you said we can start vaccinating them in the maintenance, and lymphomas who do not have received rituximab. So how soon can we vaccinate them after the intensive phase during maintenance?
So ideally, they say a gap of 3 months is ideal. Yeah, as you wait longer, your immune response starts increasing.
Thank you. Thank you so much, ma'am.
Thank you, Dr. Nishad. Dr. Farah, ma'am, your question, please.
Hi, Aisha. That was a good lecture.
Thank you.
I was wondering what you were going to speak for 40 minutes. So tell me, see, very often, especially with chemo, we can't really wait now once we diagnose a patient. So then how do we sort of schedule our vaccinations and keep these gaps?
So that's what I explained over there, that if you feel that the patient will really benefit from a particular inactive vaccine, live vaccines, of course, you can't do anything about. But if you feel that the patient will particularly benefit from a killed vaccine, or there is an outbreak of, say, influenza in the community, or your rates of something are higher, then you may vaccinate these patients either 2 weeks before or 2 weeks after the chemotherapy, as I showed you in those things, with the understanding that you may need to repeat it at the end of treatment.
But you would still have to have that 2-week gap, which sometimes one doesn't have. So that was the only thing, because very often one wants to, but then you wonder whether you'd rather wait for those 2 weeks for the vaccine or you'd rather just start off especially this comes into play, especially with Ritux. So many times you decide to give it, say for a when a lymphoma or anything, you don't really want to sort of wait for time.
I agree with you over there on rituximab. It's particularly important because then you know that you've knocked the patient out for 6 months afterwards. So if it's possible to, one should do it at least 2 weeks before.
Okay, thanks.
Thank you, ma'am. Dr. Sanjeevan Sharma, your question, please.
Hey,
Hello.
Dr. Aisha, many compliments, and it was really nice to listen to very crisp and very informative guidelines. So,
Thank you.
for me, although you had a nice slide about take-home messages, I had made my own take-home messages after your talk. And for me, the ring vaccination concept was very important because while most of the things are there, if you ask me honestly, even with the more than 15 years in hematology, probably this is something which should come in a commonsensical manner, but this is something which not many of us are following. We give vaccination to our patients, to our transplant recipients, but doing a ring vaccination within especially small kids in the family, other adults, because while most of the kids in our country do get vaccinated, but you ask a transplant, a myeloma guy undergoing transplant at 60, that how many adults in the family are vaccinated for PCP, polysaccharide conjugate vaccine for pneumonia, the answer may be zero. So I believe ring vaccination is a very important thing. And in ISBMT, we struggled for 5 years. We started our consensus thing to come up with something which you showed your chart of the PD Hinduja Hospital, the Indian Society of BMT. It was only in 2018, after 6 years of consecutive during our yearly meetings, we used to discuss what should be the optimal vaccination for Indian post-transplant people. So this exercise started somewhere in 2012. Dr. Joseph John was the lead, and we guys were sort of chipping in. And by the time Joseph could actually put up these guidelines, it was in 2018. So it took us, even amongst us as a community, we took 6 years to finally decide what to give and what to leave. So one query in that is, after the shots of the conjugate pneumococcal vaccines, even in our guidelines, we give a polysaccharide vaccine at the end of 1 year. And I saw your guidelines of PD Hinduja also replicating the same recommendation. So firstly, what is the scientific basis about this, 1 year and you do it? And my second question is, you yourself mentioned that sometimes we start at 6 months, saying that, okay, even if we do not know whether it's going to work fully or not, keeping the immune status, we may do a vaccination later on, but at least start off now, something is better than nothing. So what is that later period? I mean, if a person says, okay, I got vaccinated when I was just 6 months post BMT, and now that after how much period I need to redo my entire vaccination schedule?
So honestly, there is no guidance to that. All right. It's just an open-ended recommendation. 6 months is what is taken to be a reasonable time. Earlier than 6 months is only if there is a certain urgency to, vaccinate a particular vaccine. By and large, 6 months is an accepted time. With the vaccines for which you can measure a response, if that measurable response is inadequate, you would, of course, give a booster and see. I'm talking about hepatitis B, which is the only one we have this possibility for. In other patients, if there was someone who developed, say, GVHD or was subjected to a whole round of chemo after the transplant or any other sort of immunosuppressive therapies after transplant, they have sort of left an open-ended recommendation that you may, offer a booster to these patients. But if there is it would just be from the top of my head if I told you a year later or 5 years later. Yeah.
Okay, and what about the polysaccharide? Yeah, polysaccharide vaccine.
For your first question, this is not just for the transplant population, but for the population at large. So anyone above the age of 60 in the West, 50 in our country, the pneumococcal conjugate vaccine is recommended as protection. We understand that the pneumococcal conjugate vaccine that is available to us is 13 valent, right? The polysaccharide vaccine is 23 valent. So when you additionally give a cover of the polysaccharide vaccine, you are covering those additional strains that are not covered by the conjugate. Despite the fact that the efficacy of those may be lower, you are still you're still affording some protection in some way possible. However, Pfizer has now launched Prevnar 20, which is already available since late last year in the United States and other parts of the West. Once we get Prevnar 20 into our country, we won't require the pneumococcal polysaccharide vaccine anymore because the serotypes are, quite diverse, as in they're covering practically all the important serotypes. Yeah. Why is it a year later? For the hematopoietic stem cell transplant, they found through efficacy studies that the best time to give the polysaccharide vaccine is after a year because the immunogenicity is so low. In the other population, so if you have a highly immunosuppressed patient or someone who's at a very high risk of pneumococcal disease, like a splenectomized patient, you actually give the polysaccharide vaccine but after 8 weeks of the conjugate vaccine. If you just have a patient who is elderly and you want to give an additional cover, say a smoker, say somebody who has an increased risk for pneumonia, someone who's had pneumonia in the past, you may still give it a year later. So you can bring that year down to 8 weeks in a population that is particularly vulnerable. Again, I'm reiterating, if by chance, and that happens very commonly in our community because physicians are not very well versed with the different vaccines, that patients often receive pneumovax before they receive Prevnar. Once they receive a pneumovax, you can't give them the Prevnar for 1 year.
Thank you, sir, for that question. Dr. Asif Iqbal, your question, please.
Yeah. Am I audible?
Yes.
Yes. Please go
Yeah.
ahead.
Yeah. Yes, ma'am. Actually, I had two questions. One question is already answered. I know this is a hematological malignancy, but we do use anti-thymocyte globulin also in both benign as well as malignant conditions as part of conditioning regimens and sometimes as a part of immunosuppressive therapy. So what is the vaccination schedule for that, or anti-thymocyte globulin do you have?
That's an interesting question. And honestly, in all the guidelines and things that I read, I didn't really come across anything in particular for ATG. I would have to look it up, honestly.
Okay.
Thank you, Dr. Asif. Dr. Satish Kumar, your question.
Thank you, Dr. Amit. Thank you, Dr. Aisha, for that lucid presentation. I had a couple of questions. You in between mentioned pre-splenectomy vaccines don't give Menectra along with the conjugate vaccine, right? And to give a gap. So it's very difficult because most of the times we'll not have so much time.
So what we've started doing is we don't use Menectra, we use Menveo. Both are available in India. Menveo can be given. Menectra in particular, that brand of MCV4D, when given with PCV, studies have shown that efficacy of Menectra is lower. So avoid and use the Menveo.
Okay, I've been using both of them together, so it's really enlightening to know that don't use Menectra. Yeah. What about Haemophilus influenza? Can it be given together, the Hibrix?
Yes, Haemophilus can. Unfortunately, Hibrix is no more available as a isolated vaccine in our country. So if you really need to give it and you feel that the risk is very high, what you can do is you can use the pediatric Pentaxim. Pentaxim is a pediatric vaccine that comes with all 5 vaccines.
Diphtheria, tetanus.
That's right. The Hib part of it, component of it, comes as a separate vial.
Okay.
So unfortunately, you'd have to dispose of the rest of it or find somebody else to use it with. But that Hib component can be used from that vial if the patient is affording.
Because ideally, all the 3 are recommended before splenectomy.
That's right.
The other thing is, any particular month you would suggest to give the flu vaccine, inactivated flu vaccine every year?
Yes. So in Western data, it says pre-winter months, but and this differs for different parts of India. Now here in Mumbai, our flu is predominantly in the monsoon months, somewhere between June and September. So we recommend that the flu vaccine is given when the Southern Hemisphere vaccine comes in April. We give it in May or June. Having said that, you can, if in a particularly high-risk individual, you may give the vaccine off at any time in the year and repeat it even within the course of the year.
Okay. And the last question is this, suppose we have given the 2 pneumococcal vaccine, as you said, Prevnar 13, followed by 2 months to 1 year, the saccharide vaccine. After 5 years, what do you suggest to repeat? Is this polysaccharide or
Polysaccharide. Polysaccharide is what is recommended.
Every 5 years we should.
Yes, yes,
Okay.
because that has the waning immunity.
Okay, thank you. Thank you so much.
Thank you, Dr.
I'm
Satish Kumar.
sorry, I need to leave now. I have to be somewhere. Yeah.
Fine. So we have some questions from the audience. Okay, so we'll mail it to you.
If you could send them to me, can I sort of reply to them?
Sure.
Yeah.
Done.
Thank you so much. Thanks once again for
Thank
having
you.
me.
Thanks a lot. So that was a really interactive session, and whatever questions are left, I will mail it to ma'am and we'll get the reply from ma'am. Thank you so much for all the discussions, for joining over here. It was a good session, excellent session, and a very, very wonderful lecture. I hand over to the pharmaceuticals, Pfizer company, for the final vote of thanks. Thank you so much.
Thank you, Dr. Amit Khurana. Pfizer personally is not here, but we are grateful to Pfizer for supporting our academic activity. Thanks to you for anchoring this program, though you are out of your own city. And thanks to all the participants, discussants, and Dr. Aisha herself, and Dr. Ratna for inaugurating our webinar and giving a beautiful speech. Thanks, and have a lovely Sunday with your family. Bye-bye.
Nice. Thank you.
Thank you, sir.
Just a minute, just click the questions.